Welcome to the series on quality in healthcare, jointly organized by BW Healthcare World and Kaho. My name is Harvinder Narula, and my guest today is Dr. Anup Warrier, who's currently the Group Chief of Medical Affairs with Aster DM Healthcare India. Being an ID physician for 18 years, he has established AMS programs under different settings. The AMS program in the Aster Medcity has been designated as a center of excellence by IDSA since 2022 and as a European Collaborative Center by ESCMID since 2020, wherein he offers short training programs for European physicians in AMS. He is formally trained in implementing AMS from Radboud University, Netherlands. Welcome, Dr. Anup Warrior, to BW Healthcare World.
Thank you. Thank you. Glad to be here.
Thank you so much, Doctor. Dr. Warrior, what we're going to be discussing today is something which is really the need of the hour, which is antimicrobial resistance. Now, to start with, could you help us understand the current state of antimicrobial resistance, or AMR, in India, and why is it becoming such a critical public health concern?
So, all of us bank upon the ICMR data right now to have a snapshot of what is the resistant profile in India, because it is one of the most authentic in terms of being multicentric, like Northwest, East, and South India, all of them be covered in terms of data acquisition and also in terms of standardization of data analysis and the ability to come out with a standard reporting format. Okay, so the ICMR publishes this on an annual basis. So whatever I'm going to talk about in terms of percentages or the what you call burden comes from this data from the ICMR, which they evaluate and they update on an annual basis. So we have the 2023 data with us right now in 2024, and this year's data would come in 2025. So one of the things which, before I begin with the numbers, something which we need to understand is that even though when I say this is the best data available, there is still a skew in the data. This is because we realize that most of the data comes from urban centers or referral centers which have got access and the infrastructure for performing good diagnostics. Okay, right? Because only centers which have the ability to perform culture tests in a standardized fashion and have the ability to collect samples and the patients do come there, only those centers would be included in this data. So we know that there's a huge rural population and a lot of people out there with no access, and many smaller hospitals who don't have access to diagnostics would be left out from this data. Okay, so we need to be clear on that first. Now, coming to the numbers, the ICMR has looked at the what we call as priority pathogen list. That means the most common bugs that we isolate in various clinical syndromes across the country. And based on that, it has picked up certain major bugs where the resistance has become a challenge. So starting from the common bug called Streptococcus pneumonia that causes respiratory tract infections, where the penicillin resistance has been going up. We had less than 1% about 5 years ago. Now in many centers, it is up to 15 to 20%. To resistance in E. coli, which is one of the most common bugs that causes urinary tract infections. And all of us know that after respiratory tract infections, one of the common infections we as a layperson, the community face is the urinary tract infection. So in E. coli, one of the top-end antibiotics which we used to use, called as a group called carbapenems, and one of the examples being meropenem, an expensive parenteral drug, which used to be very effective for sick patients with E. coli infections. The resistance to that has touched to the tune of around 40 to 50%. Okay, so about half of the E. coli which we isolate in referral centers like ours, we are unable to treat with given the high-end parenteral antibiotics. Lastly, we have some hospital-acquired bugs like Acinetobacter and Klebsiella, where when we have prolonged admissions in the ICUs or we undergo complicated procedures in the hospital, we tend to have secondary infections or hospital-acquired infections, which is a fact of life. So these bugs which come in from the hospital environment or hospital setting, like Klebsiella and Acinetobacter, about 60 to 70% of our Klebsiella are resistant to this high-end antibiotic, what I mentioned as carbapenem group. And the Acinetobacter is almost 100% resistant to this. Okay. So what does this mean to us? It means to us that starting from the common community-related infections like pneumonia, which the pneumococcus related, and E. coli, to complicated hospital-acquired infections, our ability to use the common safe antibiotics has been dipping down tremendously. This is in contrast to the developing world. The developing world too has resistance. It also has resistance, but of a different profile and of a different magnitude. Okay, so in terms of profile and magnitude, Asia Pacific and in particular India and the zones around the India has been most affected by this.
And Dr. Warrior, while I was giving your introduction, we used the term ASP, which is Antimicrobial Stewardship Program. Now, what are the core components of an effective ASP, and how does it help in controlling the spread of the resistance today?
So I'll start from the second part first, because that's the baseline of why we want to do it. So when we look at antimicrobial resistance, we understand that we need to look at it from two perspectives. Okay, so one is that there is a naturally occurring resistance for which whatever you do in this part is not going to make any impact. Okay, so there are certain bugs which are inherently resistant. There is selection pressure out there in the environment due to various reasons, and bugs do develop resistance over time, irrespective of you fiddle with it or not. Okay, so there is a natural history of developing resistance. But there is also something called as an antibiotic-related selection pressure. Now, the selection pressure from antibiotics is sort of proportionally related to the type of antibiotic used. And so some antibiotics are said to be more prone to exert selection pressure on certain kind of bugs, or exert or trigger the generation of resistance in certain kind of bugs, and also the duration of antibiotic exposure. Okay, so the type of the antibiotic and the duration of the antibiotic are few of those variables which we as prescribers or users of antibiotics have something to do in terms of reducing the selection pressure of antibiotics. So when these bugs out there are exposed to these antibiotics over prolonged duration of time, they develop resistance to whatever antibiotics we are using. So this whole effort is to address this part of antibiotic selection pressure by trying to modulate the type of antibiotic in such a way that we avoid using those which would trigger resistance, or we try to preserve those which we want to use only against bacteria who has naturally acquired resistance. And we try to limit the duration of antibiotic use so that the exposure to this is less, and hence the risk of selection pressure and developing resistance is less. So this endeavor comes under the umbrella term of Antibiotic Stewardship Program. Now, coming to the first part of the question, like what are the core components of a program? Now, antimicrobial stewardship is different from stewardship program, because when we say program, it has an overarching governance structure, and it has many aspects, many components which drive the implementation, and what do you look for as a goal. So both the CDC and the WHO, and following them the national guidelines for India, the ICMR and the NCDC programs also, all of them divide these components into about 5 or 6 major headings. So it starts with a leadership for allocation of resources. So without allocation of resources, there is no start to any of these endeavors or program, because it requires manpower, it requires infra, technology, etc., etc. So that starts from the leadership, and when we come later, we'll discuss the challenges with that. But anyway, that is the starting point of the program. Following that, there is the second point is called accountability. That means the ability to have a trained person take responsibility for overseeing and running the program. Okay, so that's the second part. So you need leadership to provide resources. You need to identify a trained person who will take accountability for actually running the program on the ground. Then you need drug expertise, right? What kind of antibiotic, where, how, dosing, etc. For this, we include the competence of a clinical pharmacist. Then we come down to the core interventions or actions. That means what will we do to modify or modulate the antibiotic use and reduce the duration. So there are multiple strategies or interventions which are applied. The most largely used major two ones are what is called as prospective audit and feedback. That is where you audit the antibiotic after prescription within 24 hours and go back to the prescriber with the information that you could do this, you could do that, etc. and something called as a formulary restriction and pre-authorization. That means you put a check even before the antibiotic is dispensed. Each prescription is checked by a competent person in terms of its utility and adequacy in terms of dispensing, and then cleared. So these are the two major strategies for intervention. Then comes tracking. That means you need a monitoring system in place. This monitoring system is important because you need to prove the value of whatever things you are doing to the leadership, right? They are spending the resources, so they need to have a visibility on the value of what they are spending. You need to have the strapping because you need to show the value for the patient, because as prescribers, and you're asking the prescribers to change behavior, and the prescribers will change behavior or want to change behavior only if they're convinced it is good for the patient, right? So we need to have a monitoring system in place to go back to the prescribers and say that how the patients are doing and how we are improving on the patients. In terms of healthcare systems, they are also interested in cost. Hence, the monitoring also includes a component of cost optimization and how this program would enhance or improve your interventions for cost optimization. So you need a monitoring for all. You need to convince those who are providing resources that it is making a difference. You need to convince the prescribers that it makes a difference for the patient. And you need to convince the whole ecosystem, the healthcare ecosystem, that in terms of cost, it makes sense. So that's about the monitoring. And finally, it is about the reporting part, where this data has to be presented to the relevant stakeholders to, as I was mentioning, in the right fashion, where it hits them or it is important to them in which way. You can't present the antibiogram or the bug data to the CEO. He is not interested, right? So we need to pick and choose what is the data which is important to which stakeholder and present it to them. And finally, a lot of education endures in terms of in educating the prescriber, educating the leadership level, like why they should invest in this, educating the patients in why this is important for them, etc. So that, in short, would cover the components of stewardship program.
Got it. And Dr. Warrior, now you very beautifully articulated who are the stakeholders that or the components, but engaging the stakeholders is the key to a successful ASP. Now, could you share some strategies for involving such stakeholders such as clinicians, pharmacists, nursing staff, even patients in the stewardship efforts? I know you've touched on a part of it in your earlier answer, but I'm sure there would have been resistance at some levels. How do you overcome that? What are your strategies?
So if you look at from the top-down part, obviously the first person to be convinced is the hospital leadership, or in a public sector, who holds the key to the purse. So that, as I was mentioning, that happens two or three ways. So either there is a regulatory requirement, okay, or there is an accreditation requirement, okay. So in private sector, one of the most powerful driving forces for some sort of even a rudimentary attempt at stewardship, the accreditation has played a great role. The NABH accreditation or JC accreditation, for example, because this is something which from the hospital leadership they consider important, and what the statutes of this accreditation they are bound to look at it and invest and follow through that. So that's one part. The second thing about influencing the most important stakeholder, again, I was saying, unless the top is clear, nothing flows down. So the other part of investing or getting the stakeholder to look at the resources is, again, in a practical way, is whether this gives him a competitive advantage in terms of elevating his status among the peers. So will it be a differentiator among the peers, right? So if it is a differentiator among the peers, then in the private sector, it makes a difference, right, in terms of customer or consumer acquisition. In terms of in the public sector, and also probably very soon in the private sector, when we move on to a different payer payment system, right? Right now, it is just pay for service. So when you move to a pay for performance or a DRG based model, where there will be cap on the overall the service which the hospital offers, and you need to offer this service within a fixed amount of money, then the economic value of stewardship and infection control comes to the forefront. Because, as I was mentioning, the stewardship of the one of the founding principles of stewardship is that you modulate the prescriptions in such a way that you give just what is necessary. and you limit the duration. Now, when you limit the number of antibiotics, when you limit the use of high-end or costly antibiotics, and when you limit the number of days of antibiotics, you save cost. So now the cost is saved only for the patient. So the policymakers may not be interested, or they may not actually focus on that because it's just the patient who pays. But with the changing payment models and in the public sector, it makes a lot of sense because the government spends the money, it's the taxpayers' money. So it actually makes a lot of sense for them right now because it will reduce their acquisition, the pharmacy acquisition cost, or what they spend on antibiotics on an annual fee. So this is the pitch for the people who hold the purse strings. The clinicians per se, they are the most important part because what the drug or the prescription comes out of their pen. So unless they are influenced in terms of the right practice or prescription behavior, whatever we think out there in the room, the boardrooms, etc., is not going to happen. So one of the things which I have found useful in my practice over this 15 to 18 years in this is that the physicians or the prescribers, if they consider the AMS team as a part of their department or their treatment regimen or their treatment plan, okay, and the AMS team takes responsibility through and through for the patient outcomes, okay, then you get a buy-in from the prescriber. Okay, I'll very briefly explain that because it might be a little bit to decipher. Now, most of the AMS programs are a bench-side labs based exercise or disconnected from the physician's clinical practice. Most of them do with audit and feedback, as I was mentioning. So it's a chart review and then giving a feedback based on the chart review. So there is no interaction between the prescriber nor with the AMS team with the patient, right? So I propose and we do a model which is now globally known as the handshake model, where the prescriber, the AMS champion, and the patient, all of them interact at the same level. And the physician and the AMS member are considered as a team in treating this patient. Just like if you have a problem with your heart and lungs, you would consider the pulmonologist and cardiologist working together. Similarly, when you have an infection, you want and use an antibiotic, you want the surgeon and the AMS member to work together for the betterment of that patient. So it is not just if the patient doesn't get better with that antibiotic, right? The AMS member also take responsibility. He also interacts with the patients and takes care of it. Otherwise, it's like, fly-by-night operation. So somebody comes in, says that you do this, you don't do that, and this disappears. And when the patient has a problem, the primary physician is left holding the ball. That should not happen. So that's why to engage the physician, this handshake model is very important. Coming to the clinical pharmacist engagement and the general dispensing pharmacist engagement, the regulatory aspects are most important here. And inherently, one of the things which can do is avoid over-the-counter use. We have some regulatory set was coming now, adherence to that, and self-regulation for over-the-counter use would be important. And second is to have a very close monitoring system for drug-related or antibiotic-related adverse events. This is a strong point, again, to influence prescriber behavior. Antibiotics are prescribed left, right, and center because they are believed to be extremely safe. People think nothing happens if you have a close monitoring of prescribing and the adverse events from that, and you give a feedback on adverse events, that also will influence the prescribing behavior. So that's about the physician, the pharmacist part. Nursing has a role in terms of appropriate sampling, because inappropriate sampling drives unnecessary antibiotic use. And nurses are those, we know that mostly collect samples, urine, blood, etc., etc. They also have a role in what is called as protocol-based reminders, where removing an unnecessarily intravenous device or a urinary catheter, or giving the doctor a reminder during the rounds that 5 days of antibiotics are over, do you want to continue? 7 days of antibiotics are over, do you want to continue? So this is called protocol based reminders. So this also influences the doctors or the prescribers behavior, and obviously they have a huge role to play in infection control, which reduces the need for antibiotics in the first place. And finally, coming to the patient as a stakeholder. So here it is about patient awareness and empowerment. And like what we were mentioning before, we had an informal discussion before this. Now, it's a double-edged sword, because when we empower and educate the patient, because of the element of so-called mistrust, we sometimes fear will that cut our own throat. But end of the day, the clinical team and the patient, they are on the same side, they are on the same team. We also want to the betterment of the patient, we want the patient to get better, and patient empowerment is you can't stop it. That's the way the world is going, patient empowerment, participation, and that's the way the healthcare is going. So pushing for patient awareness and empowerment, especially in certain places where either they use over-the-counter medication or they get common prescriptions from the primary care. So these are urine cultures without any symptoms, cold, flu-like symptoms, or viral respiratory illnesses where you get prescribed of antibiotics, acute gastroenteritis or food poisoning, which is a toxin-related thing, you don't need antibiotics, clean surgeries, minor uncomplicated clean surgeries where you don't need antibiotics for healing. So these are the things which we need to put in the mind of the patient so that they are empowered to ask, if this is a viral, why are you giving me antibiotics? This is just food poisoning, do I need antibiotics? So that concludes the final involvement of the stakeholder.
And I think it's a very important aspect that you brought in. It is not about empowering the patient to take a call, but to at least ask the appropriate questions to your clinician,
Right.
just so that you're sure whether you actually need it or not.
Correct.
Now, Dr. Warrior, how can healthcare organizations, especially the corporate hospitals, leverage technology and digital tools to enhance antimicrobial stewardship practices? Because you don't really want to add more people, etc. But is there a role that technology can play?
All of us are quite familiar with the Ayushman Bharat digital mission, and again, as prescribers and being a practicing clinician myself, and I operate an EMR in my outpatient, and so I know the challenges of influx of technology into healthcare. Healthcare has been very withdrawn from the influx of technology compared to other industries. And I know the challenges because, as I told you, I'm in midst of it. I work on EMR on a day-to-day basis. However, we all realize that the way forward is going to be tech-based. There is heavy investment and a lot of visionaries who are looking at how technology can change the way healthcare is delivered or practiced in the present terms. Now, here I will just summarize with the 2 points. One is a bit of a futuristic aspect thought, but which is not impossible and which might become truth very soon, especially with such a large scale vision of the Prime Minister, like the Ayushman Bharat digital mission part. So this relates to extremely good compliance to EMR adoption and online prescriptions. Okay. So if EMR implementation is separate and adoption is separate, you can put in the best technology, but if the prescriber or the clinician at the bedside, if he doesn't enter the clinical data, doesn't enter the patient information, doesn't do the prescription on the EMR, then even though you have a technology implemented, it is empty. You have nothing of value inside the whole software. So you need a lot of effort in a different fashion to actually adopt. So again, coming back, EMR adoption with CPOE is going to be one of the game changers in this. Why? Because if you have good EMR adoption and CPOE, you generate a lot of what you can call as big data, which we know that now machine learning and big data is the in thing. You have generative AIs, a lot of other AI systems which are learned to work on this big data. So one of the major things which the doctors do at bedside is to make a flash decision that based on these 1, 2, 3, 4, 5, 6 pattern this patient has, what kind of antibiotic should I give this patient? Right? That's a simple question which we face at the bedside each day when we come to the patient with fever. Now, this kind of thing can give us real-time data. So it can tell us that for last 1,000 patients who had similar profile, this was the kind of antibiotics which made the best outcomes, right? Because it's all there. It's all there in the back end with the data, right? So that's a bit of futuristic thing. Right now, what we are looking at, there are a lot of couple of software companies who have come with standalone analytic and reporting softwares. Okay, so starting from generation of antibiogram, right? You have thousands of bugs isolated in 6 months, so this has to be compiled and structured in a way that it gives you an information the way it is useful. So that's called an antibiogram. So there are softwares which do help to do that for you. There are softwares which will monitor the antibiotic consumption. Okay, that's also a difficult thing manually. Now at a click of a button, consumption of meropenem or consumption of azithromycin, whatever, I will be able to see when I have that software. And there are softwares which help us to input the audit reports of this AMS interventions, like what you mentioned, prospective audit or etc., into the software, so that at the back end the analysis is possible and you get the reports at the click of a button. So this is the present, and what I told earlier is what I'm hoping for the future.
No, no, this is very beautiful because if you have e-prescriptions that are being used widely, at least in the urban area, well, prescribing the a particular antibiotic, if there's a red flag that can be raised for a doctor to rethink
Correct.
and confirm, that itself is a kind of a reminder to the practitioner.
Very true.
Dr. Warrior, the misuse of antibiotics is a common issue, and that's what we are discussing today, and particularly in outpatient and community settings. We are living in a country where people go to the chemist in most instances to get their medicine. Uh,
Right.
Not even prescription. I mean, they just walk into a chemist and ask them that, I have this problem. What medicine should I have? What steps can be taken to promote the responsible antibiotic use beyond the hospital walls?
So first of all, in terms of the over-the-counter use or use of antibiotics without prescriptions, the biggest culprits are the healthcare workers themselves. I have never seen a nurse or a doctor who has not taken azithromycin on his own when he had sore throat, or he had not prescribed, or he had just bought and gave the azithromycin to his friends, relatives, and family members when they had sore throat. So, if every healthcare worker himself is a consumer of over-the-counter antibiotic use, we are far away from the general customer or the consumer being aware. And you can check this out. You can ask all your doctor friends. All of them would have used azithromycin whenever they were sore throat, and all of them would have prescribed or not prescribed, just handed over the azithromycin because they don't need prescription to get the azithromycin from sample or something to all their relatives and friends when they say that I have a sore throat and cough. Okay, so it has to start from the healthcare worker. We are equally at fault because we don't practice what we preach. And when it comes to our family members and kids, we also do the same thing. So it has to start from the healthcare workers first. Then it is what we mentioned about the patient awareness and empowerment, right? So once the patient is aware of the need and where antibiotics are not useful, and equally important, I was mentioning about the adverse events. Now, why these happens? Nobody buys a chemotherapy drug off the counter and swallows it, right? So because they know it is extremely toxic, it's bad. Now, the adverse events and the bad impact of antibiotics has to be widely publicized, right? And it is not just an immediate impact, because we know that immediate impact is rare, right? An allergy, a serious allergy, a bit of GI discomfort, these are not something which will make an impact on the patient or the doctor. But there are long-term impacts which have been studied, like triggering autoimmune diseases, contributing to asthma, a link to Parkinson's, how your gut microbiome is disrupted, and how gut microbiome affects your psyche and your aging process. So there are a lot of stuff out there which we can actually use to create a bit of a scare in people that antibiotics are not like toffees. Though the immediate impact may not be very evident or very common or very serious, it does tweak with your body's system and does have an impact over long term. So that's another strategy which I would probably use in terms of public awareness and the messaging, the kind of message. So where not use antibiotics, and what can antibiotics use cause?
And Dr. Warrior, from your experience, what are some of the challenges healthcare providers face in implementing ASPs, and how can they overcome this?
So now this is something like climate change, right? So everybody is aware. So everybody is aware. Climate change is global warming. Everybody is aware, and slowly, we are getting impacted by that also, right? Our the seasonal changes, the temperature, etc. has changed. We know that 5 years ago, this was not like that. All of us are slowly getting exposed to whatever changes with the global warming and this climate change, etc. is happening. And we are, but because it's a slow sort of death, nobody is really woken up and said that we need to do this now, like COVID. Now, COVID killed a group of people together, but so there are a lot of deaths around, and everybody stood up because and said that we need to stop this now. And then magic happened. Everybody got together, public sector, private sector, different countries, inventing vaccines within months, rolling out vaccines with expedited trials, right? All to address COVID. And that's all because of the importance that people gave. And why did they give it such importance? Because it was large scale, mortality or how that was happening. So unfortunately, just like climate change, antibiotic resistance is a slow death, doesn't happen or doesn't create that kind of an impact. So one of the biggest challenges to start with is that it is not a priority for the policymakers or regulatory bodies or healthcare leaders, etc. So that's the biggest challenge. So once it is a priority, as I was telling, everything trickles top down. If it's a priority, things change and things will move ahead. So that is the first challenge of that. And it can be overcome to some extent it's a radical thought. Again, depends upon, as I tell you, it's a double-edged sword because it depends upon patient awareness and patient empowerment. I want to quote the example of tuberculosis. What government has done with tuberculosis, it made it a notifiable disease. It is mandatory to be reported under law, and the government managed to have a right information over the burden of tuberculosis, knew what kind of interventions and where those resources had to be placed for controlling TB, right? They did a pretty decent work with TB. So I would actually prefer to extrapolate those strategies to AMR. So why not make death from drug-resistant bacteria notifiable so that the burden of the program, the problem, it actually zooms up and people get a visibility on the burden. Now nobody has got a visibility on the burden. Unlike people who practice this on a day-to-day basis, the general public has got no visibility. Policymakers have got no visibility. So if you make this death from an MDR notifiable, now suddenly the public and the policymakers get a visibility and they understand at least the magnitude of the problem, staring them at their face, just like what happened with tuberculosis and HIV for that instant. So that is one part. The second is also about the whether it should be public reporting or not, right? You have a choice. Like, do you want to report to just the government, the district medical officer, and you want just the policymakers to get a look at it, or do you want it to be out there? That's an extremely challenging thing because I don't think the Indian public, as again, before this, we had an informal chat on this, that the Indian public really is mature enough to understand that problems are a fact of life, and every hospital has its own problems, and they may not look at us kindly if we say that, oh, in my hospital there is 50% resistance, or 10 people died from resistant bacteria. So a public reporting will become more dicey unless, of course, the consumer or the patient population community also matures to understand that the problems like this are a fact of life. We need to look at it and try to solve it rather than say that this is bad and this whole hospital is bad and this whole group of clinicians are bad, right? So that is the second part of the challenge. So the second challenge for me is the physician autonomy, right? So as I told you, after the the policymaker or the healthcare leader at the top, next biggest stakeholder is the prescriber, the doctor. Now, for the doctors, the biggest barrier of behavior change or moving or to a different kind of prescription is the feel of loss of autonomy. Now, why should this guy come and tell me what to do? I've been doing this since 20 years now. Why suddenly do I need to do things in a different way? No, that is the reason why I was mentioning about that handshake model, where you get in there as his team member, and so that he feels that you both of us are tackling this, both of us are in this together, and you are not just a sort of an advisor who tells him what to do and goes away. You are in it through and through to see the patient get better and go home, right? So that's how you address the physician autonomy. Then obviously the lack of resources would be a challenge, starting from the policymakers to the hospital leaders in terms of providing manpower and buying technology, etc. And last but not the least is also inadequate training in implementation science, right? So a lot of training programs are there on AMS, but what they teach is the theory. We can learn that. I can do an online course from WHO. There is a mock, massive open course from WHO. There is a online course from the universities in UK. So a lot of I need not go to a classroom or something to learn theory, right? It's adult learning. So we have, there. So one of the things is that we need to focus on training programs which actually teach the AMS champions or leaders who need to drive the program to how do you conceive strategies, how do you address these challenges on the ground with different. So what in nowadays is fashionably called as implementation science, right? The science of actually implementing your ideas or what your plans are. So training programs need to focus on how to do stuff rather than what to do, which we can just look up on Google.
I think that's a very important aspect that you brought up, sir, that, just knowing what to do is not enough. Knowing
Right.
how to actually execute it on the ground successfully is something that is the need of the hour. And I think, that is where a case study of someone who's already executed successfully should be brought out and created awareness around. Uh, Dr. Warrior, my last question to you is, since you brought up about the policymakers and few ideas around, what could be done to respond to the challenges that are there in executing an ASP, how can policymakers and healthcare leaders work together to build a robust framework for antimicrobial stewardship in India specifically? Because the challenges that hospitals face in India could be very different from what we see in other parts of the world, where the patient inflow is so huge that doctors are pressed with time issues, etc., and patient management issues.
So, in the initial part of the discussion, we took up the first question was about the AMR status in India, and we briefly touched upon the fact that in the developed world, the profile is different from what we see. Now, the one of the major reasons for that is improvement in basic hygiene. Okay, access to clean water and safe food, good air quality. Okay, so these three things, which are in the gamut of administration or governance of a country, these three have huge impact on the need for antibiotics in the first place. Okay, they tremendously reduce the number of people who get sick, and if you reduce the number of people who get sick, the trigger to initiate an antibiotic itself goes down. And that's why in developed world and all, it's not just because I don't agree to the thing that they are better, because in 2020 there was a large meta-analysis published from the United States which looked at about 20 plus university hospitals in US, and the adherence to good prescription practices was under 50% even in US at 2020. That is 20 years after huge large scale implementation of stewardship programs in the United States, still the adherence was under 50% in university hospitals. So it's not that they're better than that, but why is the resistance rate low? Because they have hit the jackpot in these things. The good hygiene, good access to clean drinking water, access to safe food, and good air quality, which means that people get sick a lot lesser, and they're getting admission and crowding the hospital with that becomes less. So that's at the policy level something which we really have to look into, because addressing the basic public health will have a significant impact on all what you are doing at different hospital level. The second is to look at vaccinations, which India is really going at it now. Right, we are expanding our list of universal immunization program. We are bringing in new vaccines in the universal immunization program, and that is the way to go, because again, vaccinations have an impact in preventing a lot of these infections, and they will again reduce the use of antibiotics. So out of this, the vaccination in India is really doing good job at it, but the public health and the general hygiene aspect, we had to pay attention to that. The second thing is about the principle of catching them young, where the AMS has to be a mandatory curriculum in the MBBS and the postgraduate training. It is already mandated by the Medical Council of India at that time and the NMC now to have a session on the AMS program in the MBBS and MD curriculum. but it should be it should be sort of modified or updated, and sort of a mandatory sort of thing that everybody should go through, so that each prescriber, when he becomes independent, he is already empowered with that knowledge about good antibiotic prescribing practices, than suddenly a team of people coming him and advising him that this is not and this is right. Even while he passes out, he is empowered with that right kind of knowledge. So that was one. The second thing is about the investment in diagnostics also, because a lot of this antibiotic use happens especially the hospital level and community level because of what we call as diagnostic uncertainty. Okay, because we do not know what is happening, we do not know what is causing this problem, and we think that antibiotics are the easiest solution, so let us give this and see if this works. Good, right? At least if it's an infection, it will go away. So diagnostic uncertainty plays a big role in day-to-day clinical practice, especially in the field of infectious diseases. So it's not like a heart attack that they look at tropi, they look at the ECG angiogram and say that yes, there is a block. For infectious diseases, there is nothing like that. If somebody comes with cough and fever, no way I can say that this is from virus, this is from bacteria, this is just at a look at him. So we need to use clinical judgment. So investing in diagnostics, which will help the clinicians have a solid background in making the right choices, is the another way at the framework level, at the larger level, which the government and the policymakers can think about. And regulatory policies, we already have a few examples like banning colistin use in poultry, and banning the over-the-counter sales of antibiotic, etc., the blue strip antibiotics. So there are certain policy or regulatory aspects out there. And finally, we spoke about the trained manpower. So we need more trained manpower in to handle and drive these AMS programs across the country, which in terms of we need ID physicians, we need clinical microbiologists, we need clinical pharmacists. Now clinical pharmacist pool is enlarging, and they're a very essential component of our programs now. So again, the government and the other healthcare providers, they can really focus and look at how we can increase this pool of trained manpower who will provide the right guidance and information to us to make the choices going forward.
Dr. Warrior, thank you so much for your time, because the conversation not only just brought out the issue, but you also not only just raised what the challenges that we are facing, but you also came up with the possible solutions to these challenges. But the two things that have resonated with me through the conversation has been, one, the 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 simple thing that you brought up, that every healthcare worker is also a consumer. So
Yes.
they to demonstrate the responsibility and responsibleness of the consumption of antibiotics. Second thing, which was very, very powerful, is that all this can turn into a reality only when we change and make this a priority. And that requires a mindset change, a commitment to make a difference in the way we treat our patients. So I think these are the two things that were very, very powerful that you brought out in the conversation. Thank you so much for your time to have this conversation, sir.